My slides are actually fairly uncomplicated. I was asked to speak a bit about what the role is for chemotherapy in pancreas cancer and what kind of side effects. Let's see if I know how to advance this. Nope.
Yeah, it's fine.
So actually, most of this has already been covered, and this isn't really so much to do about chemotherapy. How is the diagnosis made? What kinds of tests do we do? And I think Michelle and Felice have covered this ground pretty closely. Yeah, so who actually needs chemotherapy? Who needs radiation therapy? And how does the oncologist make this decision? So the patients ask us commonly, they've just been diagnosed with pancreas cancer, will I need chemotherapy or radiation prior to surgery? So at this point in time, we are still primarily considering this primary therapy would be surgery. And so we reserve the use of chemotherapy or radiation in the preoperative setting for patients whose tumors appear not to be operable at the time of diagnosis. So if the tumor involves regional blood vessels, for instance, and the surgeon tells us we don't think we can remove this tumor, or we're not sure if we can remove this tumor, then we will treat with chemotherapy prior to surgery to downstage the tumor. Our current approach to this is preoperatively to start with chemotherapy and then to follow chemotherapy with radiation and then reevaluate for surgery. How about after surgery? So this is an area that has evolved over the last several years, and it's pretty much become a standard of care now to recommend systemic chemotherapy with or without radiation following potentially curative surgery. So if Dr. Lieberman or one of our surgeons does a Whipple procedure, we'll review the pathology, assume that the tumor has been removed completely, but we will then recommend a course of chemotherapy and possibly radiation to prevent recurrence. So this is a cancer which unfortunately has a significant risk of recurrence even after a potentially curative operation. And we tend to think of pancreas cancer as both a local and a systemic disease. So the vast majority of patients will need some form of postoperative therapy to try to reduce their risk of having a recurrence. So what are the chemotherapy choices? Well, it depends a lot upon the patient, and it depends a lot on the situation in which we're recommending the chemotherapy. So gemcitabine, the brand name of which is Gemzar, is a chemotherapy drug which was approved in the late 90s for the treatment of advanced pancreatic cancer. And this has become kind of the mainstay of the chemotherapy for this cancer for well over a decade now. And Gemzar can be given alone or it can be given in combination with other chemotherapy drugs. And it's been studied in combination with multiple different drugs, 5-FU, cisplatin, taxanes, numerous of these combinations. And then there is a new combination chemotherapy which has been studied in the advanced setting, and this is a combination called FOLFIRINOX, which is actually a non-Gemzar-based chemotherapy which combines 3 potent chemotherapies, oxaliplatin, irinotecan, and 5-FU given by infusion. And when this more aggressive regimen was compared to Gemzar alone in the advanced setting, it turned out to be much more efficacious with a significant improvement in outcomes. So is there a best choice? It really depends upon the situation. When we are treating postoperatively, when a patient has had a Whipple operation and we're treating to prevent recurrence, we tend to use gemcitabine, Gemzar chemotherapy, outside of a clinical trial because that's what the data has told us works. There are trials getting started, and actually are started already, comparing Gemzar to FOLFIRINOX chemotherapy in the postoperative setting, but those results are still pending. In patients who have advanced disease, whether you use Gemzar alone, a Gemzar combination, or FOLFIRINOX, really depends upon the patient, depends upon something called performance status. How well is this patient? How able are they to tolerate a more aggressive chemotherapy? And what are the side effects? These chemotherapies are really meant not to disable patients. I mean, they're really meant to get people better. And I always tell patients that, this treatment of chemotherapy in oncology is not just to make the CAT scan show shrinkage. We're actually trying to make you better. We're trying to improve your appetite. We're trying to improve your weight. We're trying to relieve your pain. And so that these regimens, when they work effectively, not only improve the scan or perhaps drop a tumor marker, but they really should be helping our patients live better lives. These are meant to be outpatient chemotherapy. My patients, I encourage them to work full-time on chemotherapy. I encourage them to remain as active as they can, but they all have predictable side effects. So gemcitabine, Gemzar, especially when you give it alone, is fairly well tolerated. Its most significant side effect is that it can lower the white blood cell count, which are the cells that protect one from infection. So following the blood count very closely, being aware of the risk of infection, being aware to alert the doctor if a person runs a fever, and my patients are usually equipped with an antibiotic at home so that if they call me at 10 o'clock on a Saturday night with a fever, I'm prepared to start treating them. And that's actually the major side effect of gemcitabine. It's not associated with significant hair loss. It can be associated with mild nausea, mild fatigue, and in rare situations, skin rash and fever, but these are uncommon side effects. We go down to the most aggressive regimen, which is a regimen called FOLFIRINOX, which is a new regimen, which is a combination of 3 drugs, oxaliplatin, irinotecan, and 5-FU. This is a regimen which really should be reserved for patients who are really in good shape clinically, meaning that they are ambulatory, they're eating fairly well, and their ability to tolerate a more aggressive chemotherapy regimen is there. This regimen is associated with more significant side effects. It can produce much more severe effects on the white blood cell count. And in fact, most of our patients who are on FOLFIRINOX chemotherapy will get growth factors after the chemotherapy to prevent the white blood cell count from going down. They'll have a higher risk of diarrhea, they'll have a higher risk of mouth sores, and they'll have a risk for something called neuropathy, which is numbness and tingling in the hands and the feet. Again, if someone is in good clinical shape before the chemotherapy, my patients on this chemotherapy regimen are taking care of their families and going to work, but they are living with more side effects from the chemotherapy, particularly things like nausea, mild diarrhea, mouth sores, and sometimes neuropathy. Targeted therapies, so far in pancreas cancer, this question comes up a lot, and these therapies unfortunately have tended to be somewhat disappointing for treating this cancer, although erlotinib, which is an oral drug which targets something called the epidermal growth factor receptor pathway, has actually been approved for pancreas cancer in combination with gemcitabine, and it is associated, however, with significant side effects of rash and diarrhea. Avastin or bevacizumab was a drug that prevents blood vessel formation and was studied, and we were hopeful that in combination with gemcitabine it would improve outcome in pancreas cancer, but unfortunately the trials were negative. So the bottom line is that the chemotherapy is getting better for this cancer, that we're learning better how to modulate the side effects. Which regimen we use for the patient depends on whether or not we're using it pre or post-operatively, and it depends very importantly on what kind of shape the person is in when they're starting chemotherapy. And one has to use a lot of judgment. There really isn't one best answer for every patient.